I'm Dr. Gary Ansel, and for these case-based discussions, I'll be talking about Aortoiliac CTO crossing a step-by-step approach. Let's start with looking at the anatomy of an aortoiliac CTO. First, determine the underlying factor. Is that atherosclerotic thrombosis, embolization, or even aneurysmal thrombosis? The important variables in atherosclerotic disease will be the location in reference to the renal arteries, the importance or unimportance of the inferior mesenteric artery, how much calcification, and what amount of thrombus is there. So let's look at our initial approach to an aortoiliac CTO. As we just discussed, determine the etiology if possible. Next, determine if there are any side branches that should not be compromised, such as a contralateral or ipsilateral common iliac artery, an internal iliac artery, an inferior mesenteric artery, and what's the chance of compromising the renal artery or a large accessory renal artery. Next, determine the preferable access sites and wire directions. And finally, evaluate the reentry segments. Let's start with a representative case. This is a 50-year-old black male with a past medical history of coronary disease, hypertension, and hyperlipidemia. He currently has Rutherford Class 3 claudication, which affects his work in a warehouse. His ankle brachial indexes are 0.37 on the right and 0.41 on the left. Angiography that was completed at an outside institution demonstrates with a CTA an occluded abdominal aorta. This CTA and reconstructed CTA demonstrate an occlusion at the mid-abdominal aorta with reconstitution at the external iliac arteries. As you can see from still footage as well as the video from an outside hospital, they found that the mid-abdominal aorta was occluded with reconstitution at the external iliac arteries and to the common femoral arteries. Actually, not quite as evident as it was on the CTA. There are multiple therapeutic options that could have been considered, including surgery, an endovascular approach, a hybrid approach, salocizol. However, the patient stated that doubling his walking distance would not have given him enough functional capacity in his work. Or because he wasn't limb threatening, we could have just said do nothing and been very conservative other than risk factor modification and asked him to get disability insurance. If an endo approach was chosen, there are many different variables to be considered. First, access sites. Next, CTO devices. Should thrombolytic therapy be utilized to try to decrease the amount of obstruction? This will be not an uncomplicated potential procedure, so what level of hospital should be doing this? There would be a significant prevalence of perforation as well as for embolization. Ultimately, what type of devices will be utilized to maintain patency? Bare metal stents, stent grafts, ER grafts? There's data on all of these. Also, beyond that, let's look at the CTO devices. There's a multitude of ones that could be considered, from a catheter and wire up to the very advanced luminal devices or even the reentry devices. When we look at the type of repair, just the placement of the stents, especially bare metal stents, may affect patency. This publication by Grainer et al. In the Journal of Endovascular Therapy way back in 2005 demonstrated that if you cross limbs or cross the bare metal stents, your primary patency would drop all the way down to 33% with an assisted patency of 45%, where if you can keep them non-crossed, like the pants and legs, your patency is much higher. At the outside department, the patient was originally referred to surgical bypass. However, for preoperative clearance, it was discovered that he had chest symptoms. He underwent an ischemic evaluation with a Lexi scan, which was significantly abnormal. He then underwent left heart catheterization and subsequently had to have a stent for severe right coronary artery proximal stenosis. Now he has to be on dual and platelet therapy for a minimum of 6 to 9 months, depending on what institution you talk to. Certainly that made surgical bypass, especially abdominal surgery, much higher risk for bleeding. The problem was the patient was very afraid of losing his job if he really didn't come back for 6 to 9 months. So what do you do now? So after in-depth discussions and shared decision making, an endovascular approach was decided upon. We decided we would use a radial artery access to redefine the aorta and possibly assist in wire access through the occlusions. We also felt that ultrasound access of both common femoral arteries would best be our way of actually gaining access to complete the procedure. We gained access from the right radial artery and placed a pigtail catheter into the abdominal aorta. As in the pre-procedure angiography that was completed at the outside institution, you can see that the renal arteries are widely patent, and it demonstrates the total occlusion at the mid-abdominal aorta with reconstitution at the external iliac arteries. We gained ultrasound guided access into the left common femoral artery, and then took angiography of the runoff, which confirmed the CTA that there was no significant disease beyond the aortoiliac occlusion. We then switched out for a multi-purpose catheter, and through that right radial access, we utilized an 035 hydrophilic wire. And as you can see, we were able to dissect through the total occlusion and actually re-entered very easily into the external iliac artery without extending the total occlusion into the common femoral. Our initial approach included opening up the abdominal aorta and then into the iliac artery. We utilized an 035 stiff hydrophilic wire, as we talked about. This was exchanged with a 035 CXI support catheter for a torqueable 035 wire, and that was all placed into the left sheath. We then did a balloon angioplasty with a 6x100 PTA angioplasty balloon of the abdominal aorta. Certainly at that time it would be reasonable to go ahead and, if you did not have a CTA, check the amount of calcium and whether you're luminal or subintimal, making sure exactly where you are in this procedure. Through the long 6-French sheath, we took an angiogram after that dilation, and we can now see that we had integrated flow through the abdominal aorta into the iliac system, but certainly we don't have good luminal gain. At this point in time, we need to start deciding or making our decision process of what kind of prosthetic devices we're going to utilize for that. Are we just going to go ahead and open up the left and then have a hybrid approach of a fem-fem, or will we try to open up both and actually recreate this abdominal aorta and iliac vessels? Since we now had a wire externalized out the left common femoral artery, we gained ultrasound guided access to the right common femoral artery. We decided to go ahead and try to wire into that lumen that we created with the 6mm balloon. Multiple times we were not able to do that. We then placed a Palmos stent to the abdominal aorta to see if we could then drive through the stent, but again we were getting subintimal to the stent, and so we were not able to cannulate from the right side. We then placed a stent into the left iliac artery, making sure that we were not fully opposed into the abdominal aortic stent yet, and we decided we would extend that if we were successful from the right. Since we're initially not successful in obtaining access through the abdominal aortic stent from the right side, we decided to use a re-entry technique that we really like for not only this position but into the tibials, where we actually put the balloon up in the lumen from the left, so we knew we were in true lumen there, or the lumen we were creating, and we utilized a re-entry catheter. This one actually happened to be a Pioneer that we could visualize and then insert the needle into the balloon and then insert the wire into the balloon and advance that to the abdominal aorta, thus allowing us to have good access from both of the common femoral arteries to go ahead and stent this abdominal aorta and bilateral iliacs. This is really a nice technique that we utilize, especially if there's a nubbin on, as you see on the right side of the screen. This demonstrates a total occlusion of a common iliac artery with a nubbin, and we oftentimes will use that reentry catheter to insert right into that nubbin and not extend that common iliac artery occlusion up into the abdominal aorta, which can really complicate your procedures. So now we have wire access from both sides, but on the right we're at an 014 level, and all of our hardware is going to typically be using 035. So we went ahead and used a catheter to exchange to an 035, and then we placed nitinol tubular stents to create the legs on the pair of pants. Now certainly we could have utilized stent grafts at this point in time, but this was several years ago, and we utilized nitinol stents and a kissing technique without overlapping. We then took pictures of that through the right femoral sheath, and you can see that we noted just a little dissection into the external iliac artery, so we wanted to fix that. Being in the external iliac artery, we oftentimes will use drug-coated stents because of the restenosis potential for that. We also don't treat every dissection. If there's a lack of pressure gradient, then sometimes we'll leave those alone, but this patient had a significant gradient. So we placed the drug-eluting nitinol stent into the external iliac artery on the right, and we post-dilated very gently with a 6x4 balloon to 4 atmospheres. As we came down with that balloon, the patient immediately developed some right flank pain, and we could see on our arterial line that his blood pressure started to decrease almost immediately. So what do you do now? So I really suspected I had had a perforation or a rupture, and I remembered that I rarely have a good picture of that. So we actually took a little picture of what you can see here, not one that you want to see very often, that's for sure. So now I want you to actually stop for a second and think about, what would you do in this situation? What are your next moves? Certainly, as we discussed early in this discussion, we anticipated the risk of this. The balloon was inflated very quickly across the ruptured part. We actually wanted to know where the internal iliac artery was at that time, so we noted that as well, and it was a little bit farther away from the rupture, not right on top of that. We obtained a femoral venous line so that we had plenty of access for fluids and for blood products if necessary. We immediately started fluid resuscitation. Stent grafts were already in the room, and we opened up that to be able to take care of this. Trauma blood was called for because you just don't want to get behind the 8-ball. Anesthesia was called as the patient was significantly hypotensive. And at the end of the case, we anticipated the need for a Foley to look at the pressures at the end of the case, because you can get compartment syndrome intra-abdominally. As you can see, placement of this stent graft quickly took care of the rupture, and the patient quickly became hemodynamically stable with fluid resuscitation. This is not the time to really get away from your typical routine of making sure that you have an excellent final result. So a pigtail catheter was placed in the abdominal aorta, and a full angiogram was done at the end of the procedure to look and make sure we didn't have any extra perforations, no delayed filling of an interiliac artery, potentially filling the rupture. And as you can see from the movie and the heightened still frame, that you can see all the vessels being present with good collateral flow, no evidence of any extravasation. Subsequently, the patient was taken to our intermediate step-down unit. We felt that we had good hemodynamic control of him. We had blood products if we needed to. We had good line access. We looked on the angiogram and we felt that we had a good sealing of the final result. Subsequently, on the Foley, no compartment syndrome was noted, no increased pressures in the intra-abdominal that would have needed to be explored. We always try not to transfuse our patients, but he ended up getting 1 unit of PRBCs the next day because his hemoglobin continued to decrease as we had given him fluids. This discharge was then delayed for 3 days, mostly for pain control, but also to make sure that hemoglobin stayed stable because there was a lot of rebalancing. We really never did get him really high, like we didn't get him above 8 on his transfusion level. We did measure his ABIs before he went home. These were 1.0 bilaterally, and actually he was ambulating without limitation at the time of going home. He went back to work at week 3. Since he, again, lifted in a factory, we wanted to give him 2 to 3 weeks for those groins to seal in. And we actually have 2-year follow-up with normal ABIs bilaterally at 1.2, both right and left, and duplex scanning of the aortoiliac artery show wide patency, and the patient's still working. Well, I hope you enjoyed this case. I think it showed us a lot of different techniques as well as a complication management, things to consider such as type and crossing prior to the procedure, making sure you have stent grafts, making sure you should be doing this kind of procedure in your hospital, even if you're not a tertiary care hospital or not. So lots of things to consider. Thank you very much.